All right, let's go ahead and get started. Thanks for all of you who have joined the call. It was great last week to get out and see several of you at your stations and just pop in and visit with you outside for a few minutes. Happy EMS week last week. And today we're really lucky to have Bobbie Carlisle with us, who's going to present on neonatal resuscitation. And a huge thank you to Corey Cox for setting this up. This presentation that Bobbie did, she actually did down in the Utah County with the Utah County crews. And I listened in, and it was a fabulous presentation. And so we've asked her to do it up here for all of our Salt Lake County crews. I do know that we, with MountainStar Healthcare, we're sharing a lot of our education opportunities and spreading them out. So I think we're also going to have people from Northern Utah and also from Utah County in on this call also. I am recording it, so we'll be able to send it out afterwards for you guys to use and review and share with the rest of your cohorts. So I'm going to turn the time over to Bobbie Carlisle. She is an RN with her bachelor's, and she has been a NICU nurse for 26 years, and she has worked for AirMed for 16 years. And the title of her presentation is What to Expect When You're Not Expecting Neonatal Resuscitation. And so, Bobbie, I'm going to turn it over to you. Make sure you unmute your line, and if you can share your screen, we'll get to just let you go take over. And also, for any questions that you may have, if you want to put them in chat, you can type them into chat, or we'll take questions towards the end.
All right, can you hear me?
Yes.
Okay, good. This is a new format. Let's see.
Okay, so either up in the top, you can, where it says File, Edit, Share, you can do Share and then share your screen. There you go.
Okay. Working? Okay, good.
There we go. Yep.
Slideshow. There we go. Okay. There we go.
Perfect.
Right.
Thank you.
So I'm, my name is Bobbie, like she said. I created this presentation, and then I also have a cognitive aid that when I come back on me, then I'll show it to you. But I created this presentation because I'm back in school getting my master's degree, and when you're doing a master's degree, you need a project. And one of the things that I've noticed is going out, people say all the time, you know, a lot of the EMS professionals, they're always saying, oh, I'm so glad you take care of babies because I don't want to do it. And I keep thinking, you guys have like 10 times the drugs I do, and you guys give like, you have so many other things that I don't have. And so I thought, I'm going to see if I can create this presentation. So looking at some of the literature, I noticed that one of the big ones that actually led me down this path, they did a 4-year chart review in Seattle and Portland, that whole entire area. So it was a 4-year chart review. They went back, they looked at every single transport that had been done, lights and sirens, and with transporting a neonate. So first off, it was 5.3% of their total calls. Second off, the mortality rate of that 5.3% of their patient population was actually 65%. So 65% of those babies died. And 90% of the reason was because the wrong doses of medications and the wrong bolus amounts were given. And so on a parallel, another thing I'm researching is what does stress do to people? And does two things really. It makes you forget information, but it also, your brain will insert things into blank spots. And when you're in that rapid fire situation of I gotta get this stuff done, your brain will insert information. Well, the information that you know is adult, and so you will actually go back and do this, give the medications adult doses, give the boluses adult doses, or even pediatric doses. And that is the biggest reason these babies were dying. So what I did with this presentation was I took it down to nuts and bolts. And I really do hope this is like basic nuts and bolts. I mean, it's a 350-page book, so it's kind of hard to like drop it down. But I really would like feedback. I know that there was a survey that I think was sent out. And a lot of this is just data gathering. But if you could fill that survey out, that would be great. And it'll take you like seriously 30 seconds. But that will give me information of before this class, and then we can get you some cognitive aids too. But let's start this presentation. So this presentation is really, I presented it at a national conference. So some of the things you're going to see in it are kind of from that national conference. And then at the end, we do have a case presentation that was a situation that happened about a year or so ago with our teams, and we'll go through that as well. So, all right. Okay, so who is AirMed? This just talks about, like I said, we just did this at a national presentation. So AirMed, we have CAIM certification. We all have mandatory 5-year IEP experience. Our team is actually comprised of a respiratory therapist, a newborn ICU nurse.
I'm trying to.
Can you guys mute your line, please?
There you go.
Right, please.
Mine's muted. Oh.
So our team's made up of a newborn ICU nurse and a respiratory therapist, and then we have an obstetrical nurse too, because we go out on obstetrical calls. So we occasionally will have the 3-people crew. Problem is we have one team. We have one team is based at the University of Utah Hospital, and then we have multiple adult pediatric teams that are kind of the ones that you see at the other hospitals. But we'll get into that with the case review and explain what the case review. So anyway, we've been around for 40 years. All right. So NRP, what is it? It is what it is the, pull that down. Okay, good. This is what happens after the baby is born. This is transition for a baby from a world filled with fluid-filled lungs. That is the biggest difference. You've got fluid-filled lungs and a PDA, and we'll talk about the PDA. But how you transition them from being in an environment of fluid to an environment of air. That is basically what Neonatal Resuscitation Program sets up. So I like to start with what's going on inside, because if you kind of understand what's going on inside the mom when the baby is inside, then it makes a little more sense as to what things are happening when the baby comes out, why they look the same way they do, and what the transition requires. So before the cord is clamped, you have very low systemic vascular resistance. And what that means is, can you see my mouse? So what that means is, okay, perfect, thanks, Holly. When you look at a placenta and the way that it attaches to the uterus, it doesn't attach like vessel to vessel to vessel, okay? The blood flows in and out here. So you have very low systemic pressure, this very low pressure in the body. So low pressure in this vein that comes from the placenta into the heart and feeds the baby. And then you have 2 arteries that take the blood back. You want this to be very easy to transition blood back and forth. And to enable to, in order to do that, you need that low systemic vascular resistance. But you have very high pulmonary vascular resistance. Reason why is you have fluid-filled lungs. You don't need blood going to the lungs, because what do the lungs do? They oxygenate. The baby's inside with fluid, so you don't need the lungs to oxygenate. There's no reason for that blood to go there. So the blood will actually shunt through, and 90% is routed through the PDA, or the patent ductus arteriosus, and we'll talk about that in a minute. But low systemic vascular resistance allow that blood to flow, and mom provides all the nutrients, all the oxygen, everything that baby needs. If you got a pulse ox and you threw it on a baby in utero, that pulse ox would be reading about 55 to 65%. And if you got a blood gas, your PaO2 would be hanging around 20. So if you think about it, you bring a baby out, you're giving them 21%, you're really giving them oxygen, more oxygen than they have used in utero. And the saturation is 55 to 65%. There's really not a lot of stuff moving around. So the gut's not working. It's not, you don't have that motility. You don't have the peristalsis. The baby's in this tight little squished spot. So it's really not moving that much. The liver's not really working. The kidneys are sort of working, but the mom and the placenta are doing most of the work. The lungs aren't working for sure. So you don't have these high metabolic demands. There's really not a reason to have high amounts of oxygen. So once that baby starts breathing and that cord is clamped, you have a reversing of pressures to facilitate that pulmonary blood flow. Now you want the blood to flow into the lungs. And once that baby starts breathing and crying, that's when that happens. The blood flow is going to increase tenfold into the pulmonary vasculature within the first minute of life. I mean, it's super quick. And that is what neonatal resuscitation is. The whole entire thing is what happens in that first few minutes of life. Okay, so we were saying that very high pulmonary vascular resistance. So the baby's in utero, fluid-filled lungs, and the vessels are very constricted. You don't want blood going here. There's no reason for the blood to go here because it's not going to get oxygenated. It gets oxygenated by mom. So the baby comes out, you get these fluid-filled lungs, these fluid-filled alveoli, and now the baby starts breathing. You stimulate it, you dry it off, the baby's screaming, crying, and that air will come in and force that fluid out. That fluid will go into this vasculature. These vessels will now dilate, and as they dilate, that's when that tenfold increase happens, okay? So these vessels go from very constricted to very dilated, and that is transition. Remember, this is ventilation, not oxygenation. We can do this with 21%, and we do this with 21% all the time. And this is why, because you want to purchase fluid from these lungs. This is the whole transition that takes place. This is what, if you remember nothing else, this is the slide to remember, okay? You have to make that baby breathe. You have to, either the baby has to do it by themselves, or you have to provide positive pressure ventilation if they're not doing it themselves, or CPAP of some sort. You have to force this fluid from these lungs, cause air to fill these alveoli, and cause these vessels to dilate, okay? So we talked about the PDA, the patent ductus arteriosus. 90% of the blood is routed through the PDA. Remember we said that? So what is the PDA? Blood comes in from the mom, comes in the right atrium, right ventricle, out to the lungs, but high pressure in the lungs, okay? Fluid-filled lungs, very, very high pressure. So you got this pressure pushing back. Well, you have this patent ductus, this open ductus arteriosus that joins the pulmonary artery and the aorta. And path of least resistance. Remember we said low systemic vascular resistance, low body pressure. So path of least resistance would be high pressure in the lungs, low pressure in the body, the blood would go out, path of least resistance. And this is where 90% of the blood is going to dump. Just going to dump right out here and then miss a lot of this. So 60 to 70% of term newborns are going to close within the first 24 hours of life. 98 to 99% close within the first 4 days. And when this is closing, it's very wide open. And when this is closing, you're going to hear turbulence. So you're going to hear like a whooshy sound, okay? Whoosh, 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 when you're listening. If you ever get a chance to listen to a baby that's a few hours to a day or so old, listen for that. You're going to hear that turbulence as that PDA is closing. And you and I, we have a ligament here. So it closed completely, became a ligament. Cardiac issues, if present and undetected, will manifest at this time. 25% of cardiac defects are undiagnosed. Anything that's in yellow or things that I'm throwing out for you guys that go out into the field, because what's going to happen is the biggest cardiac defect is a coarctation of the aorta, where there's a narrowing right here. So if you were missing, start right here. If you were missing half of this aorta here, very narrow, if you think about I-15, all these cars are going to be coming up, and then you have like a little bit of an off ramp here that you can go on, but this is going to close off. Well, now you have one lane. So very, very low amount of blood out to the body. The heart can compensate for a while. That PDA is going to close, and then this kid is just going to get worse and worse and worse. So one of the things I tell you here is think of a baby as a devil child, okay? We're going to go 6, 6, 6. 6 hours of life. If you have like a home birth and the kid is 6-ish hours of life, 6, 8, 12, hours of life, the cooties have got him, okay? The kid is septic. If you're picking up a kid that's about 6-ish hours of life, it's probably septic. If you're picking up a kid that is 6 days of life, you're going to have a cardiac defect going on, okay? This heart is compensated as much as it possibly can. This kid just can't compensate anymore, or this heart can't compensate anymore. And these are the babies that you're going to show up, and this mom is going to hand you basically this dead kid and say, help me. And it is going to, more than likely, if you're picking up a kid that is 4 to 7 days of life, you're going to be picking up a cardiac defect, okay? And 6 weeks of life, there are a lot of people now, you remember the PKUs that you do, you go out and you poke their heel and you have them bleed on those little circles and they run the test and they check for metabolic issues. There are some people that are not doing that as much anymore. It's the whole, government trying to control us or whatever. I mean, maybe they have a valid concern, but there are people that are no longer doing that. So 6 weeks of life, you have a metabolic issue that the body is compensated for and it can no longer do anymore. Okay, so think about it. Six hours of life, the cooties. 6 days of life, you're picking up a kid, cardiac. 6 weeks of life, probably metabolic. Lock those in your brain, and generally that's what you're going to see. Okay, so yet again, 25% of cardiac issues are undetected and present, and they're going to manifest within that first week of life. Once that PDA is closed, that off ramp is closed, and you can no longer have that mixing of blood. Okay. So when you have a baby, just get in the habit of putting a pulse ox on the right hand, and this is why. Right hand, right wrist. So if you look at the way that the body is set up, comes in the right side, goes out the pulmonary artery, comes in the left side, goes out. We all know that the heart relaxes, and as it relaxes, that blood wraps around the heart, feeds the heart pumps, constricts, contracts, and shoots the blood up to the brain, okay? If you look at where the vessel that comes out that feeds the right arm and the right hand, it is immediately after that contraction and goes up to the brain and to the right heart, or the right hand, because the body doesn't want to like send it out over here and then come back and try to feed this. So when you have a pulse ox on the right hand, you are going to be getting the oxygen percentage that the brain is getting. That is what your reading is going to show you, okay? If you do it on other extremities, you have a PDA, a wide open ductus, and you're going to have a little bit of pulmonary hypertension. So you're still going to have unoxygenated blood shunting out here and out to the body, okay? That's going to be your left arm and your legs especially. You're going to see mixed blood. You're going to see unoxygenated blood still taking this path that maybe is a little bit less resistant, but that blood is going to go out here. And if you have a pulse ox on any other extremity, you're going to be chasing your tail because you're going to be getting mixed blood. So always on the right hand, right arm. And cover your butt, because if you were going to be doing any type of respiratory interventions, years ago when I first started, then we wanted a pink kid. So it looks a little dusky, let's throw a little Bobbie on him, let's throw a little CPAP on him, let's just pink him up. It's no big deal, no big deal. Well, now it is a big deal. They're linking those free radicals, oxygen, to childhood leukemia, amongst other things. But there are issues that oxygen's a drug. It's a drug for a reason. And if you are going to give this kid oxygen, make sure that you put a pulse ox on the right hand and you're getting your pulse oximetry reading, and you are saying, you're charting that I gave this kid oxygen because they were 10 minutes of life and their saturations were 82, okay? You chart that this is the reason why I gave them oxygen. All right. Okay, so resuscitation after birth. Birth means your entire baby is out, okay? Delivery means that if this is your presentation, this is a bad day, because that's a facial presentation. You don't want that to happen. That's a C-section. But if your baby's head down and the feet are out, if the butt or the feet are presenting, then the head is out, your entire baby is out, and that's when you start your APGARs, is after the entire baby is out. 10% of babies require assistance, 1% of babies require extensive measures. Okay, here in the Valley, IMC, University of Utah Hospital, and Primary Children's, we have the same neonatologists. It's the same group, and they rotate through. And so if you're talking to any doc from primaries, from IMC, or from the U, it's the exact same group. They will not resuscitate a baby that is less than 23 weeks. So I can tell you that if you have a baby that is 21 and 6/7 weeks or 22 and 3/7 weeks, you should wrap that baby back up and give it to mom. They will not resuscitate these babies, okay? If you're in another area, you probably should check with the level 3s in your area. I need to check this out. I think I heard rumors that McKay was doing 22 weekers. I'm not going to say that for 100% positive, but if you're up in that area, maybe give them a holler and find out if they do 22 weekers. But everybody else is going to be 23 weekers around here. So if your baby is 23 weeks, they have a shot. Anything less, there's nothing that they will do, okay? So now we're going to talk about the NRP algorithm. We've got this algorithm going, and this is kind of what we're going to cover, okay? So when you look at the algorithm, very first thing is birth. You're going to want to say, how many weeks gestation are you? And what does the baby look like? Good tone? Are they breathing? Are they crying? And this whole algorithm is set up. If they're crying, breathing, and term, great, they stay with the mom. If not, what do? Warm, dry stim, warm, dry stim, warm, dry stim, warm, dry stim. That is all you're going to do for the first 15 minutes, or first 15 seconds of life. You have this kid that just came out of this wet environment, so you and I coming out of the shower, you know, you're going to be cold, you're going to be wet, and you want to dry this kid off. So whatever you have handy that you can dry this kid off with, use it. Plus, this kid's been in this environment of low light, low voices, everything's soft, nothing is abrasive, you know, and now this kid is birthed out into this, all these lights and all these people talking frantically, and the rough blankets and the, you know, all of that should be enough to stimulate this kid. If it's not, you need to rub this kid's back, you need to flip this kid's feet, and you need to get them screaming and crying, because you need to have that transition take place. You have to have that fluid purge from those lungs, and the way you're going to have that happen is this kid is going to start screaming and crying, okay? So kid comes out, you've warm, dry stim for 15 seconds, pulled the blankets, put warm blankets on again, or put blankets on, rubbing, nothing. Or maybe they've got like kind of a sucky respiratory rate. What do you want to do? Well, let's reposition our airway, okay? Very first thing, airway. Throw them in a sniffing position. If you've ever taken Jason Cook's sexy bagging class, he's awesome. It's great. It's a great class. But he talks about babies as bowling balls on a straw, and this is why. Big old massive head, and if you've ever seen a kid that is just born, their heads are like a foot long by like 3 inches wide, and a big old long head. So they've got this head that they can't control with this tiny little airway. And it does not take much, plus a big old tongue too. So it does not take much to occlude that airway. This kid is like this with chin to chest. They are occluding their airway. Pull them up in the sniffing position and form an airway, okay? So you got an airway going, and this kid's gurgling or something, having some issues. What do? Well, let's suction him. Okay, so suction is one of those things. A few years ago, everybody was suctioned. We just suctioned because, I don't know, we thought maybe it would help. And then if the kid was meconium, then you would plop the kid on the bed. You would not stimulate at all. If it wasn't breathing, you'd intubate, go down below the cords, suction everything out, and then you would start stimulating this kid. Well, the problem was there were people that were doing it that didn't know what they were doing. So they didn't know how to intubate, but NRP mandated that you had to intubate, you had to go down below the cords, you had to suction this kid out. And so people were doing it and like causing a lot of trauma, like digging the back of these kids' throats out with these laryngoscope blades, and causing a lot of trauma, causing a lot of damage because they didn't know what they were doing. So NRP swung the pendulum the other way and said, okay, don't suction these kids at all. Just don't. But people were like, all right, you know, NRP says, no, we can't suction these kids. Yes, you can. You can suction these kids if they're gurgling or if there's issue with chest rise or heart rate increase, okay? And this is Mr. Supple, we'll get in that in a second. You want to suction the mouth and then the nose, but you no longer suction for meconium staining. It's no longer standard of practice that you suction automatically because of meconium, okay? So Mr. SOPA, what is it? It's steps that you can follow if your airway is not working. So you've got this kid in the sniffing position, it's not working, and maybe you need to start giving CPAP, or maybe you need to start doing PPV. You've tried and it's not working. What do, Mr. SOPA? And you're going to do a couple at the same time because you've got to reposition the head and reposition the mask about the same time. So suction the mouth, but you've got to open the mouth to suction it, and then increase your pressure, and then start thinking, maybe I probably need to intubate this kid if these corrective steps are not working. Okay, so these are your Mr. SOPA steps. All right, so airway is not working, and you've got the head back, you've got the kid suctioned out, and you've stimulated them. Okay, well, now we're down here. We've gone halfway through our 1 minute, and time goes by pretty quick. So what do we need to do? We need to assess, what is our kid doing respiratory wise? Are they apneic? Are they gasping? And what is their heart rate? Okay. So heart rate is low. They are not breathing. Very first thing we need to jump on, not cardiac, respiratory. We've got to purge fluid from those lungs. We've got to have that transition take place. We've got to dilate those vessels. How are we going to do it? If airway is not working and suction is not working and stimulation is not working, now we need to breathe for them, okay? We can either use CPAP or we can use PPV. So we're going to be breathing for them, but how are we going to do it? What's the difference? If I have a kid that has a respiratory rate, it sucks, but they have a respiratory rate, okay? Maybe they're grunting. Grunting and CPAP go hand in hand. And if you guys don't have a T-piece, contact me. Like, T-pieces are a lifesaver, and they can do CPAP up to like 6-month-old, and plus they have a pediatric one that you can give CPAP to, and it replaces the bag and mask, works on every modality, and it's awesome. It's basically like a little ventilator, but you use it in place of your bag. Anyway, CPAP. So my kid has a respiratory rate and they're grunting. It's very weak, maybe shallow, and they have some severe retractions, but they have a respiratory rate, okay? I'm going to slap some CPAP on them. So slap some CPAP on them, about 6-ish, 6 to 8. I usually start around 6. And you're going to be watching for a heart rate increase. Versus my kid is not breathing at all, okay? I don't have a respiratory rate at all. This kid is floppy, limp, doing absolutely nothing. My heart rate is less than 100, or they're gasping. I'm going to jump right onto PPV, okay? I'm going to start breathing for this kid. So, you want 25/5, 26/6, right around there, with a rate of 40 to 60 per second. You're going to be breathing pretty quick for them, so 1 a second. Okay. Per American Academy of Pediatrics, okay, a rising heart rate, not a chest rise. Chest rise works great, but you are going to be watching for that heart rate. That heart rate increase is the most sensitive indicator of successful response for each intervention. So if you're doing CPAP and this heart rate is not increasing, or you're doing PPV and this heart rate is not increasing, you need to increase your modality. You need to start PPV, or you need to intubate this kid, okay? So you're watching that heart rate. You want that heart rate. 100 is your magic number for your respiratory interventions. If your heart rate is above 100, that's great. You don't have to worry about a lot of your respiratory interventions. But if your heart rate's below 100, start on respiratory. If your heart rate's below 60, start on cardiac. So those are your 2 magic numbers, 100 and 60. All right. So I'm doing CPAP or I'm doing PPV. After a while, what's going to happen is this kid's belly is going to get bigger and bigger and bigger and bigger. Well, as the kid's belly gets bigger, their little lungs get smaller and smaller and smaller because you've got this big old belly pushing up on these lungs. Drop an OG down, vent that stomach out, okay? 8 French, 10 French, drop it down and vent that out, open that up, and drop that stomach down. And that way you have these lungs that are now able to open up completely. Okay? So CPAP. What is CPAP? This is a dead rabbit lung, okay? This rabbit is breathing, this baby is breathing, and every time it breathes, its lungs collapse, okay? What you're hearing, when you hear grunting, the kid's vocal cords are closed, and what they're trying to do is they're trying to keep this air in these lungs, okay? Problem is, every time they exhale, all of that all that air escapes out of the lungs, and so their lungs are collapsing down. So they close their vocal cords, and you're hearing that sound of them breathing through closed vocal cords, exhaling through vocal cords. So you're going to hear that grunty sound as that baby does exhalation. So baby's breathing, 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 exhaling, it's collapsing, and then you throw CPAP on this kid. Well, now every breath it takes, it's no longer collapsing down. It's no longer decreasing the lung tissue. And as the kid breathes, every time you breathe, you're going to recruit more and more and more lung tissue. Okay. Here's the deal, though. If you slap some CPAP on this kid and you take it off too soon, it's going to collapse back down. Oops. It's going to collapse back down. So you need to make sure that when you put CPAP on, you recruit some lungs, you leave it on for at least 10 minutes. Slap it on. I don't care if grandma says, hey, I want to take some pictures, you know, can you take that stuff off their face? No, you need to leave it on for at least 10 minutes, okay? Because if you don't, what's going to happen is all this nice lung tissue that you've just recruited in the last 2 or 3 minutes, you take that CPAP off, that kid is going to exhale, and you're going to be starting back to square one again, okay? That's CPAP. Okay, so we are all the way through the first minute of NRP. We've done warm, dry, stim for 15 seconds. We've assessed the airway. Are they breathing? Nope. Well, let's breathe for them, okay? Now the fun starts, okay? This is the 1%ers. You've done all this stuff and your heart rate is still below 100. You've ventilated, you've repositioned, you've done your Mr. SOPA, you've checked to see, you've suctioned, and your heart rate is below 60. Remember, 60 is the cardiac. So if it's below 100, you're doing respiratory interventions. If it's below 60, now I need to start cardiac interventions. If you look at this right here, this has the targeted sats after birth. Remember, I said if you throw pulse ox on a baby in utero, 55 to 65%. So look at these numbers. You don't need a sat of 90 until you're 10 minutes of life. So if you're throwing oxygen on this kid, you better tell him why, okay? Pulse ox on that right hand, and you're telling them, well, the baby was 3 minutes of life and my sats were 62. So that's why I gave them oxygen. Okay, great. That's what you're supposed to do. But you need to follow this recommendation, okay? Can't slap oxygen on just because the kid looks dusky or because their sats are 83 at 5 minutes of life, okay? So now this kid is not working, you're doing PPV or you're doing CPAP, they're not getting better, their heart rate is decreasing, their heart rate is not going up. What do you need to do? You need to intubate these kids, okay? And a lot of times this is what they need. If they're not responding within the first minute, they need to be intubated, okay? So we prefer uncuffed ET tubes. Air leaks are fine. If you put a cuffed ET tube in and you inflate that balloon, you can cause some tracheomalacia. You can cause some damage to that airway that this kid will never recover from. So uncuffed ET tubes are fine. Here's a tip for you. Whatever the baby's gestational age is, that's what your ET tube size is. So if you show up and the mom says, I'm 25 weeks, 2.5. If you show up, the mom says, I'm 32 weeks, 3.0. 35 weeks, 3.5. 40-week term kid, 4.0. And even a couple months old, you know, the kid's 8 weeks old, well, 48 weeks, that would be a 5.0, okay? So whatever their gestational age is, that's your ET tube size, uncuffed if you have it. Remember, every single thing have we started chest compressions? Nope. We haven't even touched any of that. Other than assessing a heart rate, we haven't done anything cardiac yet. Every single thing is respiratory. So respiratory over cardiac. And if you intubate these kids, here's a weight in kilos plus 6, that's your ET tube depth. God's honest truth, Scout's honor, I intubate these kids and then I have somebody listen because I always go deep, always. I mean, think about it, you intubate and you put it in, you know? So you get in and you just have them listen to the lungs bilaterally until they can hear equal breath sounds, and then you take your tube in place. Okay? But generally, rule of thumb, weight in kilos plus 6 is your ET tube depth. A term kid, most of the time, if it's like a normal size term kid, it's going to weigh about 3.5 kilos. Okay, so about 9.5 is where you're going to be. All right. So I'm going to touch on this just a little bit because you have these kids that you show up to and they have, this is a Pierrot Van kid that has a very recessed jaw. So a very small jaw. And this is a cleft, obviously cleft palate, cleft lip. This is a Downs baby they have very big tongues. And so you have these obstructions of the airway. If you have an LMA or an iGel, you can use them. You can't suction meconium through these LMAs. It's harder to ventilate. And I would recommend that if you show up with a kid like this and you're having issues intubating them, or I'm sorry, ventilating them, throw them prone. Because if you put this kid prone, their jaw is going to fall forward. If you put this kid prone, their tongue is going to fall forward. You put this kid prone, same thing. Tongue, everything's going to fall forward, and this kid's going to be able to ventilate that little tiny straw on a bowling ball. Okay? So slap these kids prone. All right. Now, all the way through, and now we are finally to the fun part. Remember I said 1% require, I've been doing this for a long time. 26 years. And I can tell you I've maybe done chest compressions maybe a dozen times on these kids, and I work at a high acuity facility. If you ventilate them correctly, you usually don't have to start down this path. So here's the deal with chest compressions. You have to complete 30 seconds of effective positive pressure ventilation before starting chest compressions. So think about it. What are we doing chest compressions for? We're going to do chest compressions so that we send the blood to the lungs to get oxygenated, to go out to the body oxygenated. Well, if those lungs are fluid filled, those vessels are still constricted, you're not going to oxygenate anything, okay? This kid's going to be out, you're going to be doing chest compressions, but you're not going to have oxygenated blood because the lungs can oxygenate. So you have to do 30 seconds of effective positive pressure ventilation before you start chest compressions. If your heart rate is less than 60 after doing that, then you start your chest compressions. Your compressions are 90 beats per minute, a third of the depth of the chest. We'll get into all this in a second. 3 to 1 with positive pressure ventilation. So if you're doing chest compressions, your kid is either intubated or you are doing positive pressure ventilation. You need to intubate them, and 100% oxygen is going to be delivered. So if you're doing chest compressions, there are 2 different ways that you can do it. So you can wrap your hands around the baby and thumbs on the chest and then squeeze. And the nice thing about this is you can tell the depth that you're squeezing this baby, okay? So as you're doing chest compressions, squish it, feel it. Second way to do it is 3 fingers down, one's on the nipple line, you lift that 3rd finger up and you use the 2 fingers and you compress. To tell you the truth, I use this method. I use the 3 fingers down. A couple of reasons. 1, I guess I'm old school. 2, you have a baby that is like this long, you know? I mean, a baby that is, what, 20 inches long? And you have how many people working on this kid? If you do 2-handed compressions, if you act like you're doing 2-handed compressions and you reach around this, think how much room you're taking up. Versus if I reach my hand in there and I put 3 fingers down on the chest, lift 1 finger up, and I'm doing compressions, how much room are you taking there? Because you're almost always going to have a person at the head of the bed that's intubating, a person that's beside you that is trying to get vitals and trying to get this kid hooked up to machines. You've got a person across from you that's going to be doing an IO or trying to get vascular access, okay? You've got all these people working on this small little area. And so 3 fingers to me kind of works, just because I think I take up less real estate when I do that. When you're doing chest compressions, I always tell people jump on chest compressions because it really is the easiest thing to do. So when you're doing chest compressions, here's what you're going to do. 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. You are responsible to count out loud and to say breathe. The person that is ventilating, every time you say breathe, your fingers are coming up and opening up that chest so that they can give a breath and it can open up those lungs, okay? So 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And let me tell you, I've done chest compressions on an adult 1 time and I never want to do it again. So you guys that go out there and you do those chest compressions on adults, I mean, God bless you, because I can do chest compressions on a kid. I have done chest compressions on a kid for 45 minutes. It's not a big deal. And somebody will come up, are you okay? Yep, I'm fine. Yep, I'm fine. Hey, I did chest compressions on an adult for like 3 minutes and I thought I was going to die. And then nobody tells you like things move and pop and squeak and break and crackle. That's kind of grody. But when you're doing chest compressions on a baby and you know how you have the mannequin, it really is that easy. They have very good chest compliance, like everything moves. And so doing chest compressions on a baby is nothing like chest compressions on an adult. I wish somebody had told me that. But it really is an easy job. And so you can do it the whole entire time. All right. So A, B, C, D, E. We've done ventilation. We've got our airway set up. We're now doing chest compressions. That's not working. My heart rate is still less than 60. 60 is your magic number. So what do? I give drugs. What do I give? I give epi. Okay. So if your heart rate is less than 60 despite adequate ventilation and chest compressions, now I'm going to give epi. 1 to 10,000 concentration. Here's the deal. The new boxes actually don't even have the concentration on there. It's just the brown box. Okay. So the brown box. You can give it ET tube, IV, IO. Here's my thing with that. Yet again, more literature review. They did a study with fluid-filled lambs, and they gave epinephrine, 3 doses ET tube, 3 doses IV, 3 doses IO, 3 doses EJ, 3 doses UVC. Okay. The ET tube, when they gave the dose in the ET tube, peak plasma level was 4 minutes. So they gave it 4 minutes later, peak plasma level. When they gave it any other route, any other vascular route, IV, IO, EJ, UVC, peak plasma level was 1 minute. So if you give a dose ET tube, and I'm not saying it's bad, I'm just saying if that's the route you have, you give it. You give it ET tube, okay? But slap an IO in this kid, like get a vascular access, because your peak plasma level is 4 minutes versus 1 minute. You have already given another dose because 3 to 5 minutes. So try to get vascular access in these kids. You can. All right. So here's the deal with epi. If you look at the book, it's like 0.01 to 0.03 milligrams per kilogram, and you give it IV push. I did the math for you because at 2 a.m., I can't math, but B, at 2 a.m., I really can't math. So I have it all set up so it's milliliters, okay? Because to me, a milliliter is a milliliter is a milliliter. A milligram, and I don't know, it varies depending on what you're doing and how you're doing. So 0.1 to 0.3 milliliters per kilogram IV rapid push. You want to slap that puppy in, and followed by 2 cc flush because you want to get it up to the heart, okay? If I'm giving it ET tube, it's 0.5 to 1 milliliters per kilogram ET tube, okay? Most term babies are 3.5. So what's your dose gonna be? Me personally, I give 0.1 milliliters per kilogram or 1 milliliters per kilogram. Why? Because multiplying by 0.1 or multiplying by 1, I can do that. Even I can do that, you know. So I can do that 2 a.m., snap it in, I've got it in. So I'm either giving 0.35 cc's or 3.5 cc's, depending on the route. And if you think about it, your ET tube is longer, so you're giving a higher dose, a bigger dose, okay? Versus your IV is little, so I'm giving that smaller dose. So 0.1 milliliters per kilogram, that's the right dose. 1 milliliter per kilogram, ET tube, that's the right dose. And you're repeating it every 3 to 5 minutes, okay? And repeat, repeat, repeat. And really, this kind of gets to the point where you're kind of like, is there anything else we can do? No? Okay, keep it up. Really, that's all you're doing. So reassess your heart rate and respirations every 60 seconds. You're going to put a stethoscope on, have somebody tap it out that is listening with the stethoscope. And you guys are great about putting EKG monitors on. I mean, you slap those guys on super quick. And the nice thing about having EKG, these are all actually changes in NRP. Like EKG monitor wasn't like a standard of care until very recently. But EKG monitor and then assessing every 60 seconds with a stethoscope, those are two changes in standard of care. So slap an EKG monitor on, and the nice thing is everybody can see what's going on. I've been doing chest compressions and had somebody say, is your heart rate really 125? And well, listen, so you stop doing chest compression, sure enough, heart rate's 125. So it's nice to have teamwork. You know, you have all that feedback from the team. Okay, I do include this because I know it's ethical. I know everybody has their own thoughts about it, but the literature right here says if there is no effort, no heart rate, milliliters, not milligrams, milliliters. I changed it into milliliters for you. So if there's no effort, no heart rate, no respiratory rate at 20 minutes, it's advisable to discontinue support. Your APGARs are going to show this. Your APGARs are going to be 1, 1, 1, 0, 1, 1. You're going to have a heart rate of 30 or 40 that's not going to be coming up. You're going to be ventilating this kid. You're going to be intubating this kid. You're going to be doing chest compressions. You're going to be doing epi, and your heart rate is not going to come up. So if no effort, heart rate, respiratory rate at 20 minutes, it's advisable to discontinue support. That was actually recently increased within the last 5 to 7 years, recently increased from 10 minutes because we now have standard of care is post-arrest cooling. So we do post-arrest cooling on babies, just like you do with adults, as long as they're term. They have to be at least 36 weeks. I do understand this is ethical. I am putting this in because if you show up on a scene and this kid is doing nothing and you've done chest compressions, you've intubated, you've done epi, and your kid is 20 minutes old, then you are going to be getting a kid that was probably down in utero, more than likely down in utero for who knows how long. And then this baby was delivered, and now you are seeing an hour into this assault, who knows how long into this assault. And this is one of the things that we're going to talk about during our case review. But I understand that everybody has their own feelings about it. If I show up on scene, I'm probably going to give another dose of epi. I'm probably going to do a full assessment. Everybody has. I've done chest compressions for 25 minutes. I've done chest compressions for 45 minutes. A lot of it depends on what happened before. You know, if you show up on scene and your mom's like, I haven't felt the baby move for 2 days, that's a different story than I felt the baby move around right before. Okay, so this right here is the entire 350-page book, NRP, basically in a nutshell, okay? Everything we've talked about. Is my baby 23 weeks? Yep. Warm, dry stim for 15 seconds. Assess my airway. Is my heart rate less than 100? Well, let's start breathing. If the airway breathing is not working, 30 seconds of positive pressure ventilation. You're going to reassess your heart rate. Is my heart rate less than 60? Yep. Well, let's start on our ABCs. Circulation part. So circulation with chest compressions. You're going to do this for 60 seconds and then reassess. Is my heart rate still less than 60? Yep. Give some drugs. Which drug? One only, epi. And you're going to give 0.1 milliliters or 1 milliliter per kilogram. Okay. You're going to do that for 20 minutes. And then you're going to make a decision. And really, that is NRP. That's it. I took ACLS a while back, and you guys are amazing. Like seriously, when you're giving this medication, but you can only give it if you give it this first dose, and if you give it the second dose, you have to change the dose of the medication, but you can't give it second unless you've already given this one first, and you can give this one first, but you have to change the dose if you give it second and third. Seriously, if you can remember that, God bless you. But this is NRP. Okay, that's in its entirety. All right. So I like to cover a little bit of stable, and the reason why I like to cover stable is because one of the nurse practitioners that works at primary, she was a flight nurse. She's a nurse practitioner. She's an amazing person. She's brilliant. Like that's who I want to be. But she was 28 weeks pregnant. She was up in a small town, and she thought, okay, well, NRP, that's pretty much standard of care. They know, we were taught NRP, but what happens after you finally get the baby intubated, you've done a round of epi, the heart rate comes back, everything looks okay, and now you've got this intubated kid with a good heart rate. Well, now what do you do? So she created stable. And stable this is something that you guys can use on any baby. You can use them pre-transport, post-transport, or like as you're getting this kid ready to go, think of these steps, and this mnemonic will help you figure out how to keep these kids stable. So we've done breathing to death. Like we're not even gonna cover that. Lab, I don't have a lab, you don't have a lab. Like, okay. Emotional support, hug your neighbor. We're not gonna cover that either. So we're gonna work on stabbing the baby. All right. So sugar, very first step of the mnemonic, sugar. Glucose is 50 to 110. That's adultish level. So yeah, pretty close to adult level. If they're less than 40, you need a D10 bolus. So either you need to pop an IV in and give a D10 bolus, or you need to get some glucose gel. They now have the glucose gel that you can rub on their gums. That stuff works great. And so if you're getting a glucose on these babies though, make sure that this is where you're poking. Because if you're poking here, all it takes is one poke, and these kids now have scar tissue. Their nerves, like bundle branches of nerves coming up here. All it takes is one poke, and these kids are walking on tiptoes for the rest of their lives. So make sure that when you're poking off here, okay? So get a glucose 50 to 110. And you know what? If you ever call me on transport and you tell me, hey, your glucose is this, your temperature is this, your blood pressure is this, I am blessing you and your children, because those are the things I need to know to figure out what steps I need to do next. So get a glucose, recheck it within an hour, which you probably won't have the kid then anyway. But if it's low, if it's less than 30, I'm probably checking within 15 minutes of either giving my D10 bolus or putting the glucose gel on. If your baby is septic, the cooties like chew up glucose like crazy. So if your kid's low and septic, and you're gonna know they're septic, they stink. They are, I mean, we have these kids that are delivered, they're covered in pus. They're pretty ill. But they use up these glycogen storages really, really quickly. So it would probably behoove you to slap an IV in this kid, maybe even get a culture and start some D10. Newborns of diabetic moms. So the diabetic mom will pump insulin into these babies. These babies are going to be getting 70 to 80% of whatever mom is. Remind me, I'll go through that. So gestational diabetes, if your mom is diabetic, these moms are going to be pumping insulin or glucose into these babies, okay, 70%. These babies are going to be pumping out insulin, and they're going to be pumping out insulin to take care of however much glucose these moms give them. So you have those diet controlled, everybody's taking care of those diet controlled ones that their glucose hangs around 400. So 70% of 400 is a significant amount. So these kids are pumping out tons and tons and tons of insulin to take care of this glucose load that this mom is giving them on a continual basis. Insulin is a growth hormone. So the more insulin this kid is pumping out to take care of the glucose that the mom is sending it, the bigger these kids are going to be. And that's why you get these huge kids from diabetic moms, because they were poorly controlled. And that amount of insulin shows because these kids are huge, okay? So a couple things it will do is you deliver this baby and you cut the cord. Where's the glucose? Mom has it. It's no longer going to baby. Where's the insulin? The baby is still pumping out from conception on. They've known to pump out this certain amount of insulin. So they're still pumping out tons of insulin. Their glucose load is going to drop like crazy. So if your mom says, hey, I'm a diabetic, or I've had gestational diabetes, then you need to slap an IV in this kid if it's low, because if it's not now, it will be. So slap an IV in this kid and make sure you're monitoring probably every 15 minutes is what I would do, just to make sure my glucose load stays fine. Also, 25% of diabetic moms, especially if they are insulin dependent, are going to have cardiac disease. These babies will have cardiac defects. It's something about the RNA, the DNA, as they're forming, that heart is forming, then that will be affected. And so if these moms are diabetic, then that's one of the things you need to watch for. So diabetic moms, either gestational or type 1, you're going to have kids that you really need to be on top of their glucose, and you're going to have kids that could possibly have an increased chance of having cardiac defects. Did I answer that question? So term fluid newborn rate, don't worry about this. 4 per kilo, that's what you give peds for baby. Okay, good. For peds, 4 per kilo, it's fine. This is like 3.5 or something like that. I don't know. It's math again, but multiplying by 4 is super easy. So if you're running a term newborn fluid rate at 4 per kilo, normal term kid is 3.5 of D10, beautiful. If you're giving higher than 12.5%, make sure you're infusing it through central line. You will destroy their veins. You will sclerose them if you're giving higher than 12.5%. So IV access, this is the kid's hand, and then I threw my flashlight underneath it. My flashlight doesn't heat up. It's the LED kind that doesn't heat up. So I can slap it underneath their hand or underneath their leg, and I can see these. This one right here is my favorite. You put an IV in the front of their vein. I know the parents freak out. I know they do, but I love the unicorn because hands and feet are constantly moving, or you want to swaddle them up, or you want to put them skin to skin and, you know, strap them down. The head isn't moving hardly at all. So instead of these flailing arms and legs that, you know, these IVs get tugged out of really easily, you now have this big old head and you're popping an IV in there and they stay quite well. All right. So let's talk about a little bit about IVs. When you're starting an IV on a baby, look at, I call these yours, but the bigger ones, okay? So the biggest difference between these bigger ones, and some of the 20s are like that as well, is this hole right here. So see this hole? And your 26s will be like this too. And when I was taking the picture, I forgot about grabbing a 26. But see how you have these holes right here? You have those holes. So what's going to happen is this needle is going to get into your vessel. That blood is going to come in through that needle and then immediately out this hole and fill up this catheter. So you're going to get the flash in the catheter, okay? These don't have that hole right there, so you're going to have that flash back here instead. And this is going to fill up with blood instead. So watch for that flash in the catheter here when you're using these smaller IV site or IV types. Okay, if you look at this, you have that much more. The needle's in, but you have that much more until the catheter itself is actually in that vessel. And that's probably one of the biggest things I see mistake-wise is people get that flash and then they pull the needle out, but the catheter itself is not in the vessel yet, okay? You have to go that much more. All right, so this is an IV start of a baby hand, and you're gonna assess, and babies are very malleable. So you can, we rarely use tourniquets, especially on these preemie babies, because it rips up their skin. So she's looking for cap refill, or not cap refill, venous refill, and you're looking for that quick, rapid refill. When you see that, you're gonna have a quick, rapid flash in your IV catheter. And this, babies move a lot easier than adults. Yep, and now you have this nice flat surface. So she's gonna scrub it, and as you scrub the chloroprep or alcohol or whatever you use, that's like, you know, how you tap the adult's hand. That's what this does to the babies. It makes those vessels pop up. It irritates those vessels. So scrub it really, really well. And then see how now you have these nice little vessels. 1, 2, 3. Okay. So turn it so that you can break the plastic from the metal. Okay, here's another thing too. When she gets ready to start, notice how far back she's starting. She's not starting right on top of that vessel. Reason why is baby skin is tough. And notice whenever she gets that catheter or that needle in, that skin is finally going to give. When that skin gives, if you're right on top of that vessel, you're going to shove right through that vessel. And so it's always best to kind of start back just a little bit. You've got that big old needle, but watch. Now you got the flash, go that much more, slide it off. Okay. Same thing, this one's of the head. And you know, these are things that you can do on adults too. You get those 93 sweet little ladies. Oh my gosh, I gotta turn this down. But you get those cute little ladies and you are trying to get an IV in them. This works well for them because when you're popping vessels, you're popping them because you have too much pressure. but don't use a tourniquet. Use something light like a bandana, or we use gauze strips that tie them on. Okay, so baby head. If you are trying to get an IV in a baby's scalp, one thing that helps is toothbrush with water. You take that toothbrush, you put some water on it, and that toothbrush, yet again, it's just like scrubbing them with the ChloraPrep, okay? You start scrubbing it, and look at all those IVs, or all those veins that pop up. See? Nice. If you're not getting that nice showing like that, take their butt and put something under it. So either a rolled up towel or maybe even a pillow, and you're gonna kind of put them in like a reverse Trendelenburg. Those will pop up, okay? They may be slow, but just if they're slow, then go really, really slow with your needle and you'll get that flash. Okay, so I like to kind of brush the hair aside. And once you brush that hair aside, then you have a nice flat platform, and that water will dry as you're reaching in there, or you're doing all this stuff. Okay, so there are arteries and veins kind of intermixed here. Anytime you get a vessel, make sure that you're checking it for palpation, lightly, because you can occlude it. So I'm feeling it and I feel a pulse. So it's like, oh, well, that sight's gone. So I know right now, I know that is an artery. But there's a nice little vein right here. There's another one right here. There's one back here behind the head, behind the ear that I like too. But these ones up front are nice too. So I'm doing the same thing. I'm brushing that hair flat so that when I put that tape on it, I have this nice flat surface that I can put that tape on. I also like bifurcations because then you have a point of contact here, a point of contact here. And so this vessel's less likely to roll if you have two points of adhesion making it connect. So I'm going to go for this right here. When you do it in the scalp, go shallow, 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 okay? Think like TB shot, like really, really shallow, because these vessels are really superficial. So let's see. I'm going to skip because I'm going to say the exact same thing that I talked about. You remember you've got that much needle and that much catheter, so. Okay. So really super shallow. And this baby has sugar water is what I'm giving him. They do really great. I don't get it until the very, very end. And I could see this vessel like kind of dancing around. And so I just kind of like stab it. There we go. And with the scalp, the veins almost kind of like, it's like getting an artery line. Give it just a second and then it'll relax and start filling again. Also, if the baby's screaming, it's really not a bad thing because as they're screaming, their blood pressure is going up and they're going to have more engorged vessels. So this is the way I tape every single IV that I do. I occlude it right here. You don't want to put your finger over the insertion site, but occlude it back here, and that way you're not having blood all over the place. Flush it. If this was an artery, this whole side of the head would light up. It would be white, white, white. So you're going to see some blanching because they're so superficial in the scalp, but you shouldn't see everything go completely blanched and white. If you do, that's an artery. Okay. You can use KY jelly and really lightly and then let it dry and it becomes really tacky. But this works too because as the hair dried, see how it's this nice flat platform? So I'll put the Tegaderm on and I do this with hands, I do this with legs, I do every single time I do an IV, this is how I tape it. I always put either a cotton ball or a gauze underneath because especially like your little old ladies, that plastic hub poking into their skin gets really painful after a day or so. But with scalps, it works to put that on there because you have that curvature of the head. I do it regardless. If I'm doing hand, leg, any, I put that underneath. So I'll put this first piece on just to support the flush part of it and the bevel. And tape sticks to tape really, really well. So even if you have those kids with like paintbrush hair. Okay, and then chevron it. Don't cover It will pulse back. You will get some pulsing, not always, because their vessels are super little. And so you don't get like an adult, you get that flash and that gush. You don't always get it with babies. So see, one more piece of tape here, and then I put one more here, just to, if this gets tugged. Okay. But I never tape over that insertion site, because if that IV comes out just a tiny little bit, then it's going to fold back on itself. And then you're going to have this kinked IV, and all you have to do is like kind of flush it as you pull it out and push it back in, but you can't see that if you tape over the site. Marcy, did I answer your question? You will see some, but not a lot. But you will see the pulsing once the vessel itself finally relaxes. Okay, good. So UA UVC, that's something I do. I've been trained to do. I can do it super quick. You guys are trained to do IOs. You guys are freaking awesome at IOs. You can pop those things in. Like, I'm super impressed. So you do you. If you can get an IO in this kid, brilliant, do it, okay? I need x-rays and things like that. Like, I'll do a low line, but only because I have that and I know how to do that. Most of the time I'm gonna be trying to start an IV but if you guys can get an IO in, get an IO in. Okay, all right, so sugar temperature. Babies have this increased surface area to body weight, rapid cooling. So you got these long, skinny little kids, they're going to have increased cooling, especially if they come out and they're wet and they're not dried. They have very poor vasoconstricting abilities within the first few days, so they can't constrict the vessels like you and I. And what they will do is they'll increase flexion and movement, just like you and I. You know, we get cold, so we'll pull everything in and we'll start moving around a little bit more. Babies will try to do the same thing. But if they can't, what's going to happen is babies are going to get cold and they're going to have this norepinephrine release. Okay, this norepinephrine release is going to metabolize brown fat. What is brown fat? Brown fat is something your termish babies are born with. It wraps around the heart, front and back, wraps around the kidneys. And the only thing that brown fat does is heats up. So your baby gets cold, norepinephrine will release, vasoconstriction will happen in the periphery, you know, in the hands and the feet. That brown fat will start metabolizing, and you get, it's called non-shivering thermogenesis. This area will heat up, and as the blood passes by this area, the heart, then it will heat up as well. Problem is, if your kid is sick, it's going to be tachycardic and tachypnic. I can tell you that straight up. Tachycardic, tachypnic, okay? And you have this little marathon running in. Well, now you've just cold stressed this baby, and you've added another metabolic demand on top of that. You're going to increase your O2 needs and your glucose used and needed. And all it is because you got this kid cold. What do? Wrap them in plastic. We had a call out to, I can't even remember, someplace down south, and it was a gastroschisis. And the medic, what he did was he pulled his BVM out, and he took the plastic bag and put the kid in the plastic bag and then drew the drawstring underneath his arms, and that kid stayed warm. It did great. Slap it skin to skin with mom, and skin to skin means skin to skin, okay? Don't wrap them in blankets and give it to mom. Put them skin to skin. And put a hat on these kids. Hats, their head's a third of their body size, okay? And they lose a lot of heat through their head. So make sure you slap a hat on these kids. If you have these little warmer mattresses, these particular ones, they only get to 104 degrees. If you have those little tiny ones that you snap the little thing and you put them on their heels, those get to about 116. So if you use those to warm the kid up, make sure you've got a couple layers of blankets in between that and the kid, because you will burn them, okay? In the case study we're going to be getting to here in like 5 minutes, the medic had warm towels in the dryer. That's brilliant. Like, I guess that's something you guys are trained. I didn't even know about that until he mentioned that that's what he had him do, and I was like, wow, that's impressive. All right, so last thing on stable, blood pressure. 3 types of shock. Basically, what you're going to be dealing with babies is hypovolemic. Okay, you're going to be picking up these kids that either the mom had a placental abruption, a uterine rupture, hopefully not a uterine rupture, but something's going to happen where that blood supply to the baby is going to be taken. There are babies that are born that have tight cords and the cords snap. So you have this cord avulsion. or the babies are dropped, happens, and the cord breaks and cord avulsion. Babies have a total blood volume of 80 cc's per kilo. Term kid, 3.5 times 80, not much, okay? So most of the time you're gonna see this hypovolemic kid. Hypovolemic shock results from a low circulating blood volume, okay? And most of the time it's going to be some sort of injury to the placenta, either placental eruption or previa, something like that. When you get a blood pressure, systolic, diastolic, but remember you have that PDA? That PDA is gonna let blood kind of go in and out wherever it wants to. So you can get pressures with a wide open PDA, you can get pressures of like 70/20. That's normal, that's fine. Actually, that's good. What we focus on more than anything else is the blood pressure mean. Yet again, gestational age, ET tube size, and their blood pressure mean. So if you get a blood pressure on a kid and you tell me their blood pressure mean is 42 and it's a term kid, brilliant. Perfect, that's what I want. If you've got a pulse ox, right hand only, if you got a pulse ox on this kid and it's not really working, your kid's probably hypovolemic, okay? All right, anything on NRP and stable before we get to the case review? Okay, so the case review that we're going to be doing, this was, like I said, it happened a year and a half ago. Remember I said that we have one neonatal OB team that's at the U, but we have like 7 other adult pediatric teams. And so our manager, Frankie, had this great idea that what we need is if you get a call, we have a helicopter sitting right there, but it's an adult peds team. Well, train the adult peds team to start taking care of these babies. And so they had training in neonatal resuscitation. So the scene call, the adult peds team was within 5 minutes and we were almost 30 minutes away. And so what we had was call came in, adult peds team went, and it's, yes, you do. But the adult peds team landed and they're able to give you that higher, 80 mils per kilogram total. Total blood volume is 80 cc's per kilo. Not for shock. Anything less than that would be shock, hypovolemic shock. But this is the total blood volume. But anyway, they had the adult peds team can go and give you that higher level of care, so they can help people out. And you never know what you're going to run across, because there are a lot of places that just have volunteers and they don't necessarily work 24 hours a day. And so you show up and there's like 2 people on scene taking care of this mom and this baby. And so, you know, we want to provide that more support and higher level of care, like get you guys some help. So this scene, that's what they did, was they sent the nearest available adult peds team, and then we came behind. So these pictures that you see were actually on scene. There was somebody on scene taking pictures as this was all going on. And so we have these pictures. So this was a scene call. Mom was a G4P1, meaning this was her 4th pregnancy. She had 1 living child. So she had a miscarriage, she had a 24-week demise, and that 24-week demise was actually a C-section that she had like 11 months prior. So you have this fresh, basically, C-section on this mom, and then a 2-year-old that was living. So it was a vaginal birth after C-section delivery. The midwife told her that the home birth, she was perfect candidate for a home birth. The problem is there are different levels of midwives, okay? You have level of midwives that they come to your house, they bring resuscitative equipment, they bring oxygen, they bring bag and mask, they bring medications, epinephrine, like everything for NRP, they bring, and then you have lay midwives. And lay midwives, like, okay, I'm an ordained minister, and I'm an ordained minister because I went online and I got paid my $40 and I signed up for the little thing, and I can marry people, and maybe it means a little more when I say bless you, who knows? But really, that's what this gal was she had gone online. You all you need is a high school diploma. And so she went online. So thick meconium, aspiration, and staining. This kid was born, had thick meconium very, very early on from the dad was telling us this stuff. So the lay midwife, no APGARs were assigned. This kid was born, thick meconium covering him. No resuscitation equipment was used. The midwife did state that she was using oils to resuscitate this baby, but she did not have resuscitative equipment. The dad actually tried to perform CPR. He said he wiped the face off and was trying to get as much of the meconium off as he could and was trying to do some CPR, but he didn't really know what he was doing. So he called 911 about 10 minutes of life. Our transport dispatch was called at 19 minutes of life, and because there was still a limited response. Our team was actually 23 minutes away, but you all know that it takes 3 minutes to start up a helicopter, and it also takes a few minutes to get out to the rig, so it takes a little bit of time. So we were like probably 30 minutes away by the time we got everything loaded up and going. But the adult peds team was within 5 minutes. So 911 was called at 10 minutes of life. Our dispatch was called at 19 minutes of life, and the adult peds team landed on scene at 27 minutes of life. So they arrive at scene. This is the report that I got from the nurse that showed up. And the adult peds team is made up with a nurse and a paramedic, and the paramedics are brilliant on scene. That's why they comprise it like that. The nurse does the ICU stuff, the medic does the scene stuff, and that's the way that their team is set up. So multiple EMS agencies in and around the scene. The baby was still on the floor, still in the bloody wet chucks from the delivery. So wet, cold, generalized cyanosis, floppy, no movement, some gasping respirations were noted. Midwife was in the corner of the room. The flight paramedic actually sent her to warm towels in the dryer. EMS had been doing CPR. They failed a traumatic intubation attempt. It was a bloody airway, and he said, I don't want to try again, which I don't blame him. I mean, it's hard, and you don't want to destroy that. So they were bagging 60 breaths per minute at 100% FiO2, which was perfect. The neonatal bag did not have a correct manometer, and they weren't able to give the PEEP, the CPAP. One failed PIV attempt. They did not try again. But you got to remember, they were only on scene for like 70 minutes before the next team came. So we're talking, they did all of this stuff within like 8 minutes. That's amazing. So they tried an IV, couldn't get another one. So because they didn't have an IV and they didn't have an ET tube, they weren't able to give epi. But they were doing chest compressions. And as they were doing chest compressions, this heart rate was going up to 60. That's all you have to have it, 60. I've been doing chest compressions before and my heart rate 62. And it's like, stop. If it's greater than 60, you stop chest compressions. So they were doing chest compressions and this heart rate was going up past 60. So they would stop chest compressions, continue bagging, and then the heart rate would drop. So they would start chest compressions again. So intermittent sats register with a probe on the left hand. The adult peds nurse said that when they got there, they pulled the chucks and put some blankets down and then stimulated the baby. And she had just taken this class like 3 weeks before. So she had that on her side too. But warm dried stim the baby, decrease the breaths per minute to 30. I probably wouldn't have done that because remember it's 40 to 60. So EMS they were doing a great job with 60 breaths per minute and 100% FiO2 is what they were supposed to do. So they decreased the FiO2 as well. They did put a manometer on the bag, and so they were able to get correct breaths, and CPAP was started. They sectioned for copious meconium in the abdomen. They said the abdomen was pretty firm and taut, fairly large, and then left that OG down so that it could vent their stomach. They put an IO in, gave epi twice, repositioned the SAT probe to the right hand, and they did sustain ROSC at 43 minutes of life. So this is the neonatal team coming in. This is the adult peds team on the ground. So our neonatal team is comprised, like I told you, we have an RN that's done high risk newborn ICU, and then we have a respiratory therapist, which I love our respiratory therapist. But anyway, they arrived at 48 minutes of life. They were unable to get the isolate into the house, so they left it on the sidewalk. But if you've ever seen us come in, like we're like girlfriend going away for the weekend. Like we've got all of these bags with all of our toys. So bags were brought in with the equipment. Within 2 minutes of landing, the RT had an ET tube in. So she said that she said the one thing she would change was she got on the floor and she was like spelunking. She's like, I'm in meconium, I'm in the EU, and the chexes are there, and I'm on the floor, like basically laying on my belly. And she's like, I'm halfway through this, putting this tube in, and I'm thinking, why didn't I just take the kid and put it on the bed? But hindsight. So the NICU RN took over as the code leader, and that's actually the first time a full assessment of the baby was done. They continued bagging at 30 breaths per minute, but they decreased the rate and increased the PEEP. So they were giving less rate, but they were giving bigger breaths with every breath and purging that fluid from the lungs. So they stopped chest compressions because the heart rate was maintaining at greater than 60. They did give an NS bolus because the sat probe was not reading and the blood pressure was not reading. And then afterwards, they were able to get a blood pressure mean of 53. Glucose level was obtained, it was 93, but these babies like this, they have this cortisol